My name is Katherine Ostos. I'm a third year medical resident from University of Miami in West Palm Beach. So my presentation is about a case that we had that was pretty interesting, very rare. So usually, heart failure is what is the most common initial manifestation of infiltrative cardiomyopathies. And usually cardiomyopathies remain undiagnosed because when you think about heart failure, it's more about coronary artery disease or hypertension. However, in patients that have some sort of oncological history or any other type of cancer, the cardiomyopathy could be because of the cancer itself, because of the medicines to treat cancer, or there are many different factors that can cause that in patients with cancer. So, so the incidence of metastatic disease to the heart is very rare. It's less than 10%. And this usually happens with lung cancer, breast cancer, melanoma, and hematologic malignancies. So, so this is an 81-year-old female. She presented to the ER with 1 week onset of dyspnea on exertion and orthopnea. So this is completely new to her. She'd never had any heart issues before. So she did have a history of hypertension and breast cancer. She had a lumpectomy, radiation, and without any other type of chemotherapy. And she's been in remission since like almost 20 years ago, since 2004. So she came in with your typical heart failure picture, elevated BNP, bilateral pleural effusions, and a reduced ejection fraction of 30%, and they treated her as heart failure. So as an outpatient, her echo as an outpatient, her heart failure actually improved to 40 to 45%. She had an apical thrombus. They gave her Eliquis for a short time, and they did a cardiac cath, and the cardiac cath was basically clean. She had mild non-obstructive coronary artery disease, and eventually this heart failure improved to up to 55%. However, she continued with symptoms despite managing her heart failure with diuresis and all the medications appropriately. So she was readmitted due to a couple of months later due to heart failure exacerbation, again, right pleural effusion, and they did a thoracentesis because the right pleural effusion was really bad, and then they discharged her. Because of the clean heart cath and everything just not like this being completely new to her, they did a full workup to see if there is any other cause of heart failure. So they did a cardiac MRI, and there was the ejection fraction was normal. There was a diffuse like gadolinium enhancement, and this is consistent with some sort of infiltrative disease. So when you think about infiltrative disease, you think about amyloidosis. So they did a scan, technetium pyrophosphate scan, and it was actually negative for amyloidosis. So you can see there in the image, in the little, I don't have a mouse here, but in the like the thickened part of the ventricle that looks a little bit more black than the other parts. That's kind of like the that's where the infiltration is noticed. So again, the patient had recurrent symptoms a month later, and she was referred to the hospital to have a biopsy. So when she was actually having the biopsy, that's when I met this lady. She coded during the procedure because they did a right ventricle perforation, and she developed a pericardial effusion, tamponade. We brought her to the ICU. She developed cardiogenic shock. They did a pericardial window, and we basically took care of her in the ICU until she got better. So so we checked the pleural fluid studies from the prior thoracentesis that we had. On top of that, we waited until the results of the biopsy came back, and it actually came back with breast cancer, ER positive, which is the type of breast cancer that she had 20 years before. So she was started on letrozole, and she was supposed to continue follow-up with the PET-CT and all the oncology workup as an outpatient. So the importance of this case is that that in general, in patients with heart failure, in patients with cancer, it can be caused by different mechanisms. It can be because of the radiation, the chemotherapy, and in very rare cases like this one, cancer metastases. So in general, cardiomyopathies, infiltrative cardiomyopathies, are usually misdiagnosed. And now when they detect them, it has been proved and the outcomes when you treat them. So in general, the breast cancer gets to the heart by lymphatic spread, and it's most commonly in the pericardium. But however, in the myocardium, like in this patient, the metastases there are very rare. The treatment is symptomatic, and in our case, because of the recurrent malignant pleural effusions, non-obstructive coronary artery disease, the MRI that was suggestive of infiltrative disease, and the negative pyrophosphate exam that led to the suspicion of cardiac metastases, and they did the biopsy. So in general, the pathology is the gold standard for the diagnosis of cardiac metastases. So in general, cardiac metastases should be considered in any individual with new cardiac symptoms and known malignancy. The prognosis of having breast cancer with cardiac metastases is very poor. Thank you.
Just a quick question. Are there any other options than biopsy to diagnose this patient?
So usually you can know that the patient has some sort of metastatic disease because if the pleural effusion shows the malignant cells, then you can say, oh, it's metastatic. But either way, you cannot assume that it is a metastasis or not. You definitely need a biopsy to see if it is infiltration by amyloid or if it's other type of infiltrative cardiomyopathy. So unfortunately, yes, they needed the biopsy, and because of it was a high risk procedure, that's when she got all these complications.
Thank you so much.